Hello friends, today we are going to discuss about the statistics. So first is incidence rate. Incident rate. Incidence is the number of new cases within defined population at specified time. Incidence rate is the number of new cases per population at risk at a given time. So the incidence rate formula is number of new cases within defined population at specified time upon total population at risk during the same period of time. Then the next terminology is prevalence. Prevalence is the total number of the cases within definite population at specified time, and the prevalence rate is total number of cases per population at risk in a given time period. So the formula is total number of cases within defined population at specified time, and the total number of cases per upon total number of cases per population at risk in a given time period. Now the next is attack rate. It is the cumulative incidence of infection over a period of time. It is expressed as percentage. So attack rate is number of new cases within defined population at specific time, and number of person at risk in the population. So confounding. Confounding may be important source of error. Any confounding factor is the background variable, which is different between the group being compared and affect the outcome being studied. In a study to compare the effect of folic acid supplementation in early pregnancy on neural tube effect, age will be confounding factor. If either folic acid group or placebo group tends to be consistent of older female or older female are more or less likely to have child with the neural tube defect. Mortality rate. It is a number of death within defined population at specified time. So mortality rate is typically expressed in the unit of death per 1000 individual per year. The standardized mortality ratio is the observed mortality rate divided by the expected mortality rate. The proportionate mortality rate is used to determine the relative importance of specific cause of death in relation to all cause of death in the population. Now the different type of studies are descriptive study and observational study. Descriptive study include case report, case series, survey study, qualitative studies, and observational studies include case control study, cross-sectional study, cohort study, and ecological study. Experimental studies, that is randomized control trial, double blind study, single blind study, unblinded study, and crossover study. Case series and case report. They consist either of collection of report on the treatment of individual patient with same condition or of report on single patient. They are used to illustrate an aspect of condition, the treatment, and the adverse reaction to the treatment. They have no control group, so they have no statistical validity. The benefit of case series and report are that they are easy to understand and can be written up in very short period of time. Now, observational studies. Research don't change anything. They only observe and document which occurs in one or more group of the patient. So, when an observational study compares two groups, it may be categorized as being either case control study, consider difference between groups in the past, and cross-sectional study, consider difference between groups at present time. Cohort study considers difference between the groups in the future. Now about case control study, it is a retrospective study. This means that you begin at the end and then work backwards to hunt for possible cause. It usually compares the disease and healthy group and look back in time to see what they have done differently in the past and that may have led to the disease. These studies are concerned with the etiologies rather than treatment, and they are more suitable for rare cases. This study cannot calculate incidence, prevalence, or relative risk, and the results are expressed as odds ratio. Case control studies are less reliable than either randomized control study or cohort study. For example, study in which colon cancer patients were compared and they were asked what kind of food they have been eaten compared to healthy population. Now about cross-sectional study, a study that examines the relationship between the disease and other variable of interest as they exist in defined population at specified time. It is usually used for qualifying the prevalence of the disease or risk factor, the accuracy of a diagnostic test. This study allowed determination of prevalence and relative risk, but not the incidence. It cannot evaluate the hypothesis about the causation, and it does not take into account the timing of exposure to risk factor relates to the development of the disease. For example, is the current prevalence of cystic fibrosis in the population of adolescents. Another example is their association between overweight and diabetes mellitus. Now about cohort study. Cohort study, two or more group of the subject are selected on the basis of their exposure or lack of exposure to particular risk factor or agent. So for example, drinking alcohol or not, smoking or not, eating high fat diet or not, and follow the group forward in a time to see how many in each group develop particular disease. Cohort studies are used to establish the causation of the disease or to evaluate outcome and impact of the treatment. When randomized control clinical trial are not possible. So cohort study may be prospective, that is exposure factors are identified at the beginning of the study and defined population is followed into the future. Retrospective, that is past medical records are defined population and are used to identify exposure factors. So prospective cohort study are more reliable than the retrospective cohort study. Cohort studies allows determination of incidence and relative risk, but not the prevalence. Now, disadvantage includes the large number required for rare outcome, problems of the dropout bias, and changes in the practice during long-term follow-up period. Now about ecological study. Here the unit of analysis is a population rather than individual, and the association across the different population is investigated. So case control study cannot calculate incidence, prevalence and relative risk, and results are expressed as odds ratio. Cross-sectional allows the determination of the prevalence and the relative risk, but not the incidence. Cohort study allows the determination of incidence and relative risk, but not the prevalence. So case control studies are highly prone to selection and recall bias. Now the randomized control trial. It is the mainstay of the experimental medical study normally used in testing new drugs and treatment. In randomized control studies, there are two groups, one treatment group and the one is control group. The treatment group receives the treatment under investigation and control group receives either no treatment or standard treatment. The control group does not necessarily consist of normal, healthy individuals. Patients are randomly assigned to all groups. Placebo is the pharmacologically inert dummy, identical in appearance to the treatment, and should normally be used for control group when there is no conventional treatment available. Randomization means that each patient has same chance of being assigned to either of the group regardless of their personal characteristics. Note that random doesn't mean haphazard or systematic. Randomization helps to avoid selection bias in the assignment process. It also increases the probability that differences between the group can be attributed to the treatment under study. Allocation concealment means that allocation is unknown before the individual is entered into the study. RCT may be either double blind, neither that means neither patient nor medical staff knows which treatment patient has been randomized to receive. It could be single blind, either patient or medical staff or physician doesn't know. Or it is unblind, that means both medical staff and physician knows. It is the preferable that studies are blinded because knowledge of the treatment may affect the outcome and introduce a bias in the result. Now about the classification of the RCT. On the basis of hypothesis, it is a superiority trial, non-inferiority trial, and the equivalence trial. On the basis of outcome of interest, it is explanatory and pragmatic. Study design in the randomized control trial are concurrent parallel study design and crossover type. Type of RCT: animal experiment, human clinical trial, preventive trial, risk factor trial, and cessation experiment. Advantage of RCT: considered most reliable form of scientific evidence used to find cause and effect relationship. No selection bias and multiple outcome variables can be measured in a single study. Disadvantage of RCT: it is expensive, longer study duration, ethical restriction and administrative issues, participant and observer bias, and non-compliant of control threaten the validity of study. Now, stages of drug development in the clinical trial. Preclinical, pharmacology and toxicology in lab animals. Phase 1, checking for safety, that is safety, tolerability, pharmacokinetic, pharmacodynamic in healthy individual or patient. Phase 2 is checking for efficacy and dosing. Initial treatment studies to determine efficacy and dosing of drugs in small number of patients. Phase 3 confirms the result, that is large RCT comparing new drug with current gold standard treatment. Phase 4 is the post-marketing surveillance, that is long-term safety and rare event in all patients prescribed the drug. Now the crossover study. In crossover study, each patient receives treatment or placebo in random order. Crossover studies are only suitable for chronic disorder that are not cured but for which treatment may give temporary relief. There should be no carryover effect of treatment from one treatment period to the next. Sometimes it is necessary to leave gap between end of first treatment and start of next to ensure there is no overlap. This gap period is known as washout period. The outcome may or may not be normally distributed. Now about systemic review. It is comprehensive survey of the topic that takes great care to find all relevant studies of highest level of finding from individual studies in an unbiased, explicit, and a reproducible way, and present balanced and impartial summary of the findings due to consideration of any flaws in the evidence. In this way, it can be used for the evaluation of either existing or new technologies and practices. A systemic review is more rigorous than traditional literature review and attempt to reduce influence of bias. The difference between systemic review and meta-analysis is that a systemic review looks at the whole picture while meta-analysis looks at specific statistical picture. Now, the next is meta-analysis. Meta-analysis is systematic, objective way to combine data from many studies, usually from RCTs, and arrived at full estimate of treatment effectiveness and statistical significance. So, meta-analysis also combine data from case control and cohort studies. The result of meta-analysis is expressed as odds ratio and relative risk. Now, the steps in the meta-analysis: define research question and specify a hypothesis, define criteria for inclusion and exclusion studies, literature search, selection of studies on specific subject, aggregate finding across the different studies, selection of meta-regression model. Then three type are simple regression model, fixed effect meta-regression model, random effect regression model. Combine study results using different approach, for example, inverse variance method, Mantel-Hansel method, and Pareto method, and then report results. Meta-analysis sequential components: define the research question, perform literature search, select studies, extract data, analyze data, statistical analysis, and report result. Now, what is non-inferiority trial? Non-inferiority trial is the study that evaluates safety and efficacy of new treatment by comparing it to existing treatment. Thank you, guys.